presentation today. And I'm going to go ahead and introduce Dr. Lee and turn it over to him for today's talk. Dr. Stephen Lee is a board-certified pediatric and general surgeon. He completed medical school and residency at UC Davis and fellowship at Seattle Children's. Dr. Lee returned to Seattle Children's in February of 2023 as our division chief for pediatric, general, and thoracic surgery. And he's pleased to be here today to present this talk to you. Dr. Lee, I'll turn it over to you. Oh, you're muted.
How's that?
Perfect. Thanks.
Great. Okay. Well, thank you for having me, and thank you for everyone for joining. I am here to answer questions and do what I can to present some cases about pediatric common disorders that we see in pediatric surgery and kind of update management. Feel free to interrupt me anytime and ask me anytime you want questions or what have you. Happy to stop anytime. I don't actually see the chat, and I don't actually see anyone raising their hand, so I'm going to have to rely on others, Aaron and others on the webinar to help me with the questions. Okay, here we are as we get started. So first, I have no financial disclosures. And then what we'll do is just kind of give a little bit background of our division, and then really the bulk of the talk, or all of it, will be reviewing common pediatric surgical conditions, management, any new updates. And we'll do this really through a case presentation standpoint. A little bit more about me, just really quickly. I did come from the Los Angeles area. And if I'm a little distracted, we were actually right in the heart of the fires that was going on yesterday. So we haven't heard if our house is up in is still there, but we know that the family is still there and safe, which is great. But having said that, I've been practicing in the Los Angeles area for 20 years, and I actually practice in every possible practice setting. So one of the things I truly miss is the interactions with our pediatric colleagues. I used to see them all the time, have lunch with them, talk with them all the time. I worked at the Kaiser system for a long time, then I worked in the county system, and then a small private practice before working at an academic center. And now I'm up here at Seattle Children's, and couldn't be happier. So here is our current division, our faculty. There's actually, it goes on to a second page, but we're all here, have different, we all practice general surgery, but we all have different interests and specialties that we practice. We have three others that are part of our division. Dr. Patrick Healy, who is actually also part of the transplant division. And really does a lot of our hepatobiliary work with us. We have two new hires coming in the spring this year. Dr. Shin Hiroshi from UC Davis, who is going to really kickstart our fetal surgery center, as well as Brian Coakley from Mount Sinai in New York. And his main task is to help with the surgical aspect in the management of obese patients, and really start our bariatric program for adolescents, which will be the first in the Northwest. Here are some of our programs that we have. We have a comprehensive congenital diaphragmatic hernia program, reconstructive pelvic medicine program, and I use this only to show that if you have any patients with any of these problems or issues, feel free to send to us, and we're happy to see them preoperatively, considerations for surgery, or even postoperatively. You'll all see patients that may have had a Hirschsprung's disease or imperforate anus and need additional follow-up. We're here to see patients of any kind. We have a fetal center, as we mentioned. We just started an aerodigestive center, really managing the esophageal atresia, tracheoesophageal fistula patients. Mentioned we are going to restart a comprehensive obesity management program with our medical colleagues, and start a bariatric surgery program as well. We see a lot of patients with solid organ tumors, and we have a robust ECMO or ECLS program, including ECPR, and we see a lot of patients with chest wall conditions, just to name a few. And really quickly, as far as operations, we do them at Seattle Children's, we do them at Bellevue. We also go to Tri-Cities and do operations out there. And our clinics are not only in Seattle and Bellevue, but we're in the South about 2 times a month. We're in the North area 2 to 3 times a month, and Tri-Cities every other month, which may actually go back to every month. So enough about all that. Let's jump into some common disorders, and the first would be pilonidal disease. So this is a 16-year-old patient with pilonidal disease that you're seeing in your clinic. And this patient has had 2 previous abscesses drained in the past 6 months. They were both drained in the emergency department. And the current exam shows this. As you can see, there's lots of pits, there's a lot of hair coming out, and there's still some evidence of chronic disease. So unfortunately, I can't see people to see if you can give the correct answer, but what is the most appropriate management of this patient? Would it be to do laser hair removal, minimal pit excision, unroofing and marsupialization, wide local excision, or excision with flap closure? So we would recommend minimal pit excision. And in general, for pilonidal disease, really less is more. The less we can actually do and preserve normal tissue, the better we are and the better outcomes we have. And more importantly, the better recovery patients have with pilonidal disease. So when we look at pilonidal disease, we know that the cyst is really not a cyst in the true sense of the word. It's really a reaction to the buried hair underneath the skin and deep down inside that grows long and gets debris. Ultimately, hair can never be sterile, so it'll sterilize, so it will be infected and can form into really bad abscesses or low-grade infections that end up finding their way out to the skin and form sinus tracts, as you can see by this image. When they form these tracts, you can see the root of the problem is still very deep, and you see these little openings or pits, as was shown in that picture that I showed earlier. And a lot of times these little cavities will lead to multiple sinus tracts, even though there's only one underlying cavity typically involved. So as I mentioned, less is more. So the less invasive techniques really has been the mainstay of treatment. We do what's called the GIPS procedure, which is minimal pit excision. Some people will just pick the hairs out of them and try to clean them locally. Some will unroof the whole area and clean it out and let that heal by secondary intention. But the less is better compared to the previous wide excisions that we used to do. And we know that the outcomes are significantly improved with decreased recurrence rates and much faster recovery than our previous wide local excisions. So as you can see here, we want to avoid wide local excisions with midline closures. So what is minimal pit excision? So what we do is, you can see that this is some more images where the pits are located, and we use these little almost like punch biopsies that our dermatologists use, and we actually just core them out, as you can see what's going on here. And what that does is it allows us to get down into the cavity. And then from there, it gets a little bit bigger, and then we're able to, through those little openings, really clean out the underlying cavity, get all that debris out, wash it out, and therefore leaves a very small incisions there, very small wounds to care for, and much better recovery for patients. In postoperative care, we know that they have minimal pain. A lot of patients, all of our patients we send home now with just Tylenol or ibuprofen. What's really key is their aftercare. So if they come see you in the clinic afterwards, we really want to promote just the hygiene and the care of these wounds. And it's as simple as taking a warm bath twice a day, soaking the area, or showering twice a day and really cleaning out the area. We just don't want any more hair to get trapped in that area as this heals. There's really no packing of the wounds that's really needed like we had in the past. So it's packing is usually associated with pain and discomfort, and just parents don't like doing it, patients don't like having it done. And so this technique avoids all of those things. And what we've seen is a very low recurrence rate when we do this minimal pit excision or Gibbs procedure. And even those that do recur, they often don't require surgery, but usually local wound care. So I'm going to pause and see if anybody has any questions. Again, I can't see the chat or anything else.
So far, we don't have any in the chat and no hands are raised.
Okay, great. Next is going to be Pectus excavatum. This is something that I personally do quite a bit of, and our center does quite a bit of. And as you all know, this is a typical patient with Pectus excavatum. You can see how deep that chest is, and here's a classic example of the CT scan for Pectus excavatum, where the heart is being compressed and pushed entirely into the patient's left chest. They'll often present with shortness of breath, typically with exercise, more of the aerobic activities than the anaerobic activities. But as you know, we've seen a lot of patients even short of breath, just walking a couple blocks, walking upstairs, any kind of, they can be very, very symptomatic, even without exercise. As you recall, the old technique was to make a big incision across the skin to remove all the costal cartilage along each side of the sternum, as shown here. And then that will free up the sternum to allow us to move the sternum forward and set it in a better position. We would usually have to fracture the sternum and kind of reshape it to allow the sternum to move forward. And give a nice shape of the chest, which this is a great operation to do so and has had good results. But this is an old picture of black and white because we haven't done this in a long time. But you can see it leaves a big scar across the chest, even though there's a significant improvement of the pectus deformity, as you can see here. So as you all know, we currently do this with a minimally invasive technique. We pass a bar. This is called a Nuss technique. Some people call it a minimally invasive repair of Pectus excavatum, or MIRPE. But basically, with the patient asleep, we put a camera inside or a thoracoscope inside the chest, and then we pass the bar in front of the heart, behind the sternum, and comes out the other side. We flip the bar over, and you can see how that will push up the sternum, allowing a great repair. This is another kind of graphic of this, of what happens, how we pass the bar and set the bar with the camera in place. Here are some intraoperative photos. As you can see, the patient's head is to the screen right, and the feet are to the left. And you can see the chest is in place with the chest the Pectus excavatum. And in the picture in the top right-hand side, you can see that the chest wall is caving down and really compressing the heart. This is the bar that's going to be passed across the chest. And once it's flipped, which you can see the intraoperative photo below that, you can see how that chest rises up and gives a lot of room between the chest wall and the heart, as you can see. And then this is an immediate postoperative picture, and again, you can see how the chest is completely reconstructed. And this is a very fresh post-op picture. It's post-op day 1. You can see the steri strips in place. You can see how small the scars are. They're off to the side. This little one is where we place the camera, but you can see the significant improvement that's seen right away on post-op day 1. Now, I'm sure you know that this is a very painful operation, or had been a very painful operation. We would treat patients with epidural catheters, then transition them to a PCA. And a lot of patients were on oral pain medications and really more of the opioid type medications for 4 weeks or even longer after surgery. And this was made it tough recovery and very painful operation. But probably about 5 years or a little bit more ago, we've been starting to do cryoablation. And cryoablation, as you can see in this picture here, this is an intraoperative photo of the chest wall on the inside, is we actually freeze the intercostal nerves, which run along the inferior border of each rib, and we freeze usually intercostal nerves 3 through 7 on both sides, and that significantly improves the recovery because it numbs the entire chest wall, and the amount of pain medication required has significantly decreased, and patients are out of the hospital much faster. So when I was in my prior institution, when we first implemented this, we had patients who were in the hospital about 5 days after surgery. After cryoablation, it averaged usually overnight. It was 1.4. That was because the first few patients, we weren't sure that we were too nervous, even though they were ready to go home. We kept them an extra day or two. But now almost all patients will go home the next day after a Pectus excavatum repair. And then the number of discharge opioid tablets significantly decreased. It was initially 62 before we started doing cryoablation. And then now it's 3 tablets. And a lot of that's just in case, because as you know, it's very difficult to get, if a patient does need it, it's very difficult to get even a few tablets to the patient with all the regulations with opioid medications. But most go home just on Tylenol, ibuprofen, and a muscle relaxant. And a lot of patients are actually off of all pain medications within the first week. So this cryoablation has significantly improved the recovery of patients undergoing Pectus excavatum repair. Study compared actually looking, this wasn't our center, but another center from Kansas City. They looked at epidural catheters, PCAs, and cryoablations, their techniques. As you can see in the bottom line here, that the average length of stay is 1 day with cryoablation, when both epidurals and PCAs used to be about 4 days, very similar to our results. And then the time to oral pain medication only was less than 24 hours when there was cryoablation. Again, very similar to our results. And these results have been very consistent across many institutions. And so cryoablation has been pretty standard of practice now and significantly improves the recovery. Let me pause to see if anyone has any questions on Pectus excavatum.
We have someone who raised their hand, so let me just unmute Thatcher. Thatcher, you should be good.
So you can hear me okay?
Yes, can you speak up a little bit louder?
Yeah, sorry.
Perfect.
Yeah, thank you for this. This is fascinating stuff. How do we in primary care know at what point to refer someone for a NES evaluation? We don't want to over-refer or under-refer. Is there a way of gauging the severity other than shortness of breath, which would be kind of obvious, about when somebody needs to be referred?
No, great question, and I probably should have covered that a little bit more in detail, so thank you for asking that. In general, we're happy to see patients at any time. We don't offer the operation typically until the end of their growth spurt, so at the end of puberty. So typically, the typical age is about 15 to 16 years of age. But as you know, as they go through puberty or go through their adolescent growth spurt, a couple things happen. One is if a very mild pectus that you've been following condition, whether it's a carinatum or excavatum, can significantly change during their adolescent growth spurt. So when they're 12, 13, 14 years old, it gets dramatically different. And it's at that age that their parents stop seeing them with their shirts off or what have you, because as you know better than I do, the kids don't really, they have different interaction patterns when they go through all these things. And all of a sudden, that's why it's like, whoa, where did that happen? But that's very common for us to see. And we go through all that with the parents. As far as severity, I usually mostly go by symptoms because the actual depth of the pectus may not be fully predictive of the severity. The severity only really matters, and it's the Pectus index or the Haller index. And that's where we measure the width of the chest on the CT scan divided by the depth. And the larger the number, the more severe. And what insurance companies want to see is that number being greater than 3.2. And we usually can eyeball that when we see these patients, and usually don't get a CT scan unless we're planning to do surgery, because a lot of patients come, hear what we have to say as far as what we expect and all of these other things, and they don't want to have surgery or what have you, which is totally fine. We just want to also follow them and provide them with the appropriate information. I would say that usually anyone less than 12 is probably a little young to refer to us. But again, we just had a patient who was 8 or 9 years old, who really, the parents were really concerned and wants to use, I didn't include this in this talk, we use a vacuum bell, which looks like a big plunger on the chest, and we can use those in smaller kids. We hadn't been doing that here at Seattle Children's, but we started to do, I did that quite a bit in my prior institution. So we have brought that here, and a few select patients are trying that vacuum bell. So it's a long-winded answer. So I hope I answered your question. Does that answer it, or do you have a follow-up question I can address?
Sorry, it wouldn't let me unmute. No, that's great. Thank you. I appreciate it.
Okay. Yeah. All right. Any other questions on Pectus excavatum?
I don't see any, so I think you're probably good to proceed.
Perfect. And thank you for the question. I love questions. Okay, our favorite, appendicitis, right? I think we all know a lot about appendicitis, but it changes and there's all sorts of things going on. Just to kind of review basics and what's new in appendicitis. And I find this to be very regional. Again, coming from the LA area and coming up here, there's some slight differences. But I don't want you to be surprised if you see some of our patients in your office and saying, "Hey, what are they doing up there at Seattle Children's? Are they crazy?" And so we may be doing different things as we move forward. But as you know, appendicitis is the diagnosis is really based on the history, physical labs, and imaging. We can use something called the Pediatric Appendicitis score, which can be looked up, and it gives us a rough estimate of, if someone's low risk, intermediate risk, or high risk of having appendicitis. I like this scoring system because it just kind of normalizes everything. It puts objective numbers to things. So if an emergency room physician calls me and says, "Hey, I got somebody with these things and it's a low risk," it just kind of helps me understand where we're starting from. So it's something to keep in mind, easily looked up, and we use that particularly in research studies. It's helpful. As you know, our main diagnosis is with ultrasound, and when the appendix is visualized, it's as good as a CT scan, which is great. Where I came from, my prior institutions, we weren't great at ultrasound. So we had to kind of figure out different ways to work around that. But in general, if you don't see the appendix on the ultrasound, it's like not having an ultrasound done at all. It doesn't provide you a lot of information. You have to see the appendix for it to be a good study. But when we do see it, it's an excellent study, and as you know, there's no risk of radiation with that. What we do great up here is we get very few CT scans. CT scans are outstanding. And I was just going to say, I've just had a couple recently where we didn't know what was going on, got a CT and it was appendicitis. And I would never have guessed this was appendicitis. Your symptoms are not appendicitis. I don't even think we should do an operation, but we did anyways. And they had appendicitis, lo and behold. So CT scans are great, but we really try to limit their use because of the radiation. As you know that better than I do. So then next would be a contrast enhanced MRI. And that's also an outstanding study. It's very accurate with respect to sensitivity, specificity, the positive predictive value, and the negative predictive value. And here's an image of what an MRI looks like with the appendicitis, the appendix being inflamed and lit up, as you can see by that arrow. The limitation of MRI is the MRI itself. It's not always available because of all the other uses for the MRI. Also, kids have to hold still, and they in certain ages have a harder time holding still for the MRI due to the closed space of the MRI. But having said that, once we diagnose appendicitis, I know one of the things that always comes to question is you ask 10 surgeons and you get 10 different answers on what do you do with the antibiotics after surgery. And often you guys get called and say, hey, what do we do? I don't know what to do. But in general, if it's straightforward appendicitis, basically the recommendation is 1 dose of IV antibiotics preoperatively, and that's usually given just before the operation starts or at the time of the surgery, and then no other antibiotics are needed. And then I know we like to make up numbers on days of antibiotics postoperatively for those with perforated or complicated appendicitis, which could be a gangrenous, a contained perforation, or free perforation. Which agent to use, it really depends on each hospital's antibiotogram, what's most sensitive. We've been using Zosyn. That's been good for the region. Other transferring hospitals use Zosyn quite a bit as well, and it goes with us. But basically, we only need to use that until patients are afebrile, they have return of GI function, and their pain is controlled. And then we send patients home, plus or minus with oral antibiotics. We used to say the standard of care was patients need to stay a certain number of days with IV antibiotics. Now we've shortened that to once you meet this discharge criteria, you can go home, whether that's day 2, day 3, after surgery. I would send them home to complete a overall course of a 1 week of antibiotics. That's being challenged now. We're part of the Western Pediatric Surgery Research Consortium, and we're starting a pilot study where patients are going home without antibiotics. And so far, the results have been very, very promising, showing no differences in infection rates afterwards. So if you get a call from one of our patients saying, hey, I had bad perforated appendicitis and I didn't go home with antibiotics, I want a prescription for it, that's not uncommon anymore for us to send patients home without any additional oral antibiotics. And of course, if you have any questions, you can always refer to us, but that's something you may see moving forward a little bit more often. Now, the newer thing is, this is the whole spectrum of appendicitis from the normal appendix all the way to the bad perforated appendix. And we just saw one just on New Year's Day. I had a patient with 2 weeks of symptoms, bad perforation, abscess, the whole works. And we know for those patients on that end of the spectrum, we try to treat non-operatively with antibiotics. We do a drain with our interventional radiology colleagues. And then treat them with antibiotics, get those patients home, and then do an interval appendectomy about 6 to 8 weeks later. We know that's pretty routine practice. And I know a lot of you help us take drains out or manage these drains or see these patients in between while they get their interval appendectomy. So thank you for doing that. It really helps us a lot. There are those that are a little earlier with perforated appendicitis. These are usually patients that are less than a week of symptoms, usually 3 or 4 days. They have perforated appendicitis. They're pretty ill appearing. Those we definitely recommend appendectomy. We give IV antibiotics, recommend a laparoscopic appendectomy at that point. The newer thing right now is the treatment of acute appendicitis, whereas the standard of care has always been laparoscopic appendectomy. I think a lot have heard of non-operative management with antibiotics alone. So, what I'm focusing on today is not those on the far right with the perforated delayed diagnoses with an abscess. We know we treat those non-operatively, but can we treat acute appendicitis non-operative with antibiotics only? And if so, why would we want to do that? So basically, the question then comes is, what is the optimal timing for an appendectomy in patients with acute appendicitis? We all used to think it was an urgent operation. We used to did them in the middle of the night quite frequently. Then now we're able to push it up, to the next morning, and it's more of a semi-elective operation. And then now we're asking the question, do we even need to operate at all? Can we just treat with antibiotics alone? And I think the key point here is that antibiotics, once we start to administer the antibiotics, that's why it's key when you guys make the diagnosis. A lot of you make the diagnosis in clinic. You send them to your local emergency room. They agree with you, say we have appendicitis, but they want to call us and transfer to us depending on where you're practicing. Once they start the antibiotics in the emergency room, they're really halting the disease progression. We know that. And the next question was that can we just treat with antibiotics alone? So those old days of if we don't operate in the middle of the night, it's going to progress to perforation. That's not true. We know that the disease, the progression is halted by antibiotics, even now to the point where we think we can treat with antibiotics alone. And so what's the rationale of trying this? Well, first of all, for even though we think we can do laparoscopic appendectomies pretty routinely, pretty straightforward, there are still complications associated. We have minor complications in up to 15% of patients and serious complications in up to 5% of patients. We also still have a negative appendectomy rate of around 5 to 7%. That's kind of a national data. I think here in our region, we're a little bit lower than that, but that's still kind of what the numbers show nationally. There's pain and disability associated with with surgery. Even though patients can go home the same day as the operation, which we do quite frequently, they often miss a week of school just because it's still a big operation and they're still pretty sore. And therefore, that's days that are missed in school from the patients, but more importantly, days that probably are missed by the parents having to care for their patients at home, care for their children at home. Cost is a factor. I mean, on average, a cost of a lap appy is about $7,000, and there's about 70,000 laparoscopic appendectomies in children a year. So the healthcare dollars do add up. And you combine that with the fact that we are able to diagnose it much more accurately with our preoperative imaging, especially with ultrasound, as I reviewed earlier. And then our oral antibiotics the bioavailability has now, in some instances, are as good as IV bioavailability. So all of these things push for a rationale of trying non-operative management. And then finally, some may actually say the appendix, or some advocate that appendix may have actually some functions. It may be a safe house for the good bacteria for our gut microbiomes. It could be a source of mesenchymal cells as well to help damaging tissue repair. And some even advocate there may be some sort of role in the immune function that can help alter the cardiovascular and cancer risks in patients. So lots of reasons to try non-operative management. And we've done it for a while, and all the studies that we've done has shown that it's safe and effective with respect to the treatment of non-operative management. There's very little complications associated with it. The big question is, if I get appendicitis and treat it non-operatively, is it going to come back perforated, and is my child going to be sick, or is your patient going to be really sick from it? The answer is no. The rate of perforated or complicated appendicitis is the same as the first time of appendicitis. And usually families are so good at diagnosing it because they've been through it before, they're back to the ER very quickly and treated very quickly. So there's no increased risk of complicated appendicitis when you first treat with antibiotics alone. The question is it effective? And how do we measure effectiveness? We measure it, but the success rate is those not undergoing an appendectomy. We can also look at disability days compared to surgery, quality of life compared to surgery, and cost compared to surgery. But the questions all families really want answered is, what is the success rate of non-operative management or antibiotics alone? And this is cumulative data both in adults and children, and it's very interesting that the results are almost exactly the same. We see that when patients first appear and they're treated in the emergency room, they get a dose of IV antibiotics. They're usually admitted overnight, And then if they do well, we send them home the next day to finish a 1-week course of augmentin oral antibiotics. And that initial admission, we're about 90% successful in treating. So 9 out of 10 patients can go home, do fine, not need surgery. At 30 days, after they complete their antibiotics, 30 days after their initial bout of appendicitis, that risk is of needing their appendix out is very low. It's a 90% success rate in children. And then at 1 year, there is a recurrence rate. So about 75% of patients, roughly 70% of patients will remain free of needing an appendectomy at 1 year. And associated with non-operative management is there's actually less disability days for both the patient and the parent. There's similar or better quality of life, again, for the patient or parent, and similar or lower cost. This is just a kind of looking at the data again in a different way. For time's sakes, I'm going to move forward. The big thing here is, are we ready for outpatient non-operative management? As I mentioned before, we've been sending patients, we would admit patients overnight, keep them overnight, see how they do, and then send them home the next day. So now the question is, can we actually treat these patients as as an outpatient, meaning getting a dose of antibiotics in the ER and sending them home safely to finish their antibiotic course? And so we looked at this at my prior institution. We started offering this to patients in October of 2021. We did a brief ER observation period. We called them the next day to see how they're doing, and then we did a virtual or in-person clinic visit within a week to again discuss different options for them. Here were our inclusion criteria, pretty straightforward. I'm going to bypass that just because of time. Here's kind of all the patients we treated over a 1-year period. We weren't as busy as we were up here with appendicitis, but I just want to bring your attention to this side of the patients. We had 33 patients who met inclusion criteria for non-operative management. 10 actually chose to undergo lap-appy, and the other 23 decided to choose non-operative management. And we did give the parents a choice whether they wanted to go home from the ED or be admitted overnight. 9 wanted to be admitted overnight, and 14 discharged from the emergency room. And when we looked at our data really quickly, you can see those discharged from the emergency room, the average length in the time in the emergency room was 7 hours. Those compared to those that were observed overnight, there was a 24-hour stay, and then those comparing those to the operating room. And the rest of the data just shows that the patients are all very similar with respect to age and severity of their appendicitis. We had no adverse events. There were 17% ultimately underwent appendectomy at 1 year, which is a little bit lower than the 27% that was quoted earlier. Our follow-up was only about a half a year overall. So we concluded that this is a safe and feasible management option, and we're currently underway planning a multi-institutional study to confirm these findings. So what does that mean to you? What it means is, the reason why I'm embarking on this is because, as you know, we get a lot of transfers from all over the state, all over the region. And if we can treat these patients at their home institutions and follow up with virtual visits, we can avoid these transfers to our hospitals and all the hardships for parents and families. And that will decrease hospital resources, costs, and prevent these transfers, which is really what I'd like to do. But we can show that it's safe to send patients home from the emergency room with non-operative management. And then if the patients decide that they go home, say they're from Eastern Washington, and they say, hey, we changed my mind, I want to have the appendix removed. We say, fine, no problem. We can actually schedule that as an outpatient elective operation, as an interval appendectomy. And therefore, we could, again, avoid all those middle of the night transfers and all the hardship for the family in doing so. And we can better partner with our communities in providing care and avoiding all the unnecessary use of hospital resources. So before I get to everyone's favorite topic, gastrostomy tube, I think I went a little too fast. I'm going to stop and ask if anyone has any questions about appendicitis. I know I went over non-operative the most because I think that's kind of the newest thing that we're doing. And I know coming from the Los Angeles area where we had patients readily walking in, their families saying, hey, we don't want surgery. And so we got a very, we got on this treatment path very early. However, I noticed in coming here, in at least Seattle Children's, the overwhelming majority of patients undergo an operation. We're just starting to see some patients ask for non-operative management, and now we routinely offer it to those who actually qualify for non-operative management. But still, the overwhelming majority still choose surgery. But let me pause to see if anyone has any question about appendicitis in general or non-operative management of appendicitis.
As of right now, we don't have any questions in the chat and no raised hands, so
Okay. Great.
we probably covered it perfectly.
All right. Well, probably spoke a little too much about it. It's one of my interests, but okay, we'll move on to gastrostomy tubes. I know you see a lot of our patients with gastrostomy tubes, so I just want to go over some basic things because you'll see a lot of them and have to manage a lot of patients for us. And again, we thank you for that. We're always here to answer questions, but a lot of patients will turn to you first, so we appreciate all your help with this. As you know, the stomach is based for a gastrostomy tube. The basic principle is the stomach is sutured to the abdominal wall, and the tube goes in, and there's some device at the end of the tube that prevents it from falling out. And most often it's a balloon tube. So that's what the basic premises of the gastrostomy tube placement. Now, what are problems we often see with gastrostomy tubes? We see leakage around the tube, we see granulation, and we see infection, falls out, it breaks, all of these things I'm sure you've all seen many, many times in your practices. The first thing is really identifying what type of tube is it. So all of the tubes will tell us what type of tube it is. They're all going to tell you the size. As you can see here, this is a typical long balloon tube, meaning the tube just hangs out. It's not a skin level or button tube, but it's really a balloon. As you can see, the balloon is inflated, and that's what's keeping this tube from falling out of the stomach. But every tube will tell you what it is. It'll tell you the size of it. This is a 12 French. It'll tell you which is the actual balloon port and how big how many cc's of water can go into the balloon port. As you can see here, it's 5 milliliters. The other smaller port is for medications, and then the big lumen is for the feedings, as shown in the diagram above. Now, these long tubes, the balloon tube also comes in the form of button tubes, as you can see, and this is the ones you're more commonly being seen is these button tubes where you have to insert a connection tubing or adaptive tubing into the tube. That tubing, when it's inserted, it activates a one-way valve. So, you know, when it's removed, there's a one-way valve so the tube shouldn't leak out any material just because it's skin levels. There's a one-way valve in there. So once that's the adaptive tubing is put in there, that'll deactivate it, allow the feedings to go through and be used like any other regular tube. But what'll happen is when you're not using it, you remove that tubing, and then it's flushed to the child's skin and minimizes the chance of it being dislodged or caught during activities, and it makes it more less noticeable. So when they're going to school and all of those things, they're happier about that. So those are just kind of basics on gastrostomy tubes. And again, you can see, again, this is a 20 French tube. The length of this is 1.7 centimeters. That's the stem of the overall length of this tube. And again, the balloon port is marked to show where you put the balloon if you need to put more water in the balloon. All right, the first question is, what is this? Well, it's a button tube, we know that, and it's a balloon tube because there's a balloon port, but this area here is granulation tissue. So the common things for granulation tissue is silver nitrate or steroid cream. The steroid cream is effective but can take a while. Silver nitrate will only work if it's can be repeated frequently. For optimal results, I've used this quite a bit. This was taught to me by one of my nurses about 20 years ago. Is if the patient came into clinic today, I would treat it with silver nitrate. Then I would send them home with betadine sticks and silver nitrate sticks. And then the parents would clean this with betadine tomorrow, clean it again the day after tomorrow, and then repeat that 3-day cycle until the granulation tissue is gone. What happens is the silver nitrate dries it up. It kind of gets it to slough a little bit. But the betadine actually prevents new growth of granulation tissue. And so that's why this is a very effective mechanism to treat granulation tissue. Our team will still do a lot of steroid cream. That's been highly effective, but I found this to be faster and just works, especially for those very large areas of granulation tissue. The next complication we often see is this, and maybe hard to see, but there's some redness here and all these other things. So this is what we consider an infection. And the main thing when we see somebody with redness around the tube, the one thing we want to ask ourselves is there an underlying fluid collection or abscess that's developed? That can be done by a physical exam, or you can get an ultrasound. So if you see a patient like this, get an ultrasound, there's no fluid under there, and there's nothing on your exam, you can just treat with antibiotics, and we often just treat with Keflex because this will then just be a little cellulitis around the tube. But the antibiotics won't be effective if there's an underlying fluid collection. So that's what you want to rule out when you see this in your clinics. This is often seen too, which is just kind of the site doesn't look so great. And what this actually is leakage around the tube itself. And so what ends up happening when leakage around the tube is, as you can see, the balloon is typically secure to the inside of the stomach. But if this balloon slips and the tube is loose, then that's when the fluid will leak around the balloon and into the skin. And so one of the questions we often get asked is, can we just place a bigger tube? Well, that actually won't do it much. What we really need to do is make sure the G-tube is secure and not moving around. And that is what will make sure that the leakage will stop and help not irritate the skin around it. If it's the long tube, as I mentioned earlier, you just tighten that little ring or flange to make sure it's secure. If it's a button tube, sometimes patients will lose weight and they actually need a little bit more water in the balloon. Sometimes we just need to change it to a shorter tube. So those are the kind of tips to look out for if you see this in your clinic. Next, we see or get calls often is as the G-tube fell out, or they may just show up in your office with a G-tube in hand and it fell out. And the question is, what to do at this point? Really, the main thing is timing of when that gastrostomy tube was placed. If it's been in a while, you can't really hurt by putting something back into the tract. But if it's something that's less than 2 weeks old, so we do an operation, patients often going home the next day or two. If they show up in your clinic and the G-tube's out, that one I would not recommend that you try to place that back in. I would send them to the emergency room, call us, we can direct them. But they really should, those patients should really have a wire placed through that tract, try to place the tube over a wire under fluoroscopy. A lot of our IR colleagues, very great at doing this. Our adult colleagues are great at doing this. So something that can be taken care of locally, but it's something that's what we would recommend. If the tube has been there for 2 to 6 weeks, it's okay to try to put the tube in place. But if you do that in your clinic, I would definitely send them, get a contrast study to make sure that it's okay before you use it. It's not bad that you put a tube in place, and if it's not in the right place, that usually won't harm the patient. What harms the patient is if we have a tube floating freely in the intra-abdominal cavity, and then we feed that patient. That's what's going to harm the patient. So if we're not sure, always get a contrast study to be sure that the tube is in the stomach. And then if it's more than 6 weeks, you can replace it. It usually will go fine. If it goes easy, you don't need a contrast study. You can just start using it. You might want to flush it with a little water or something, make sure they're okay. But usually that tract is so well intact that you're not going to harm anything. And then if the tube is broken or it doesn't fit, just get any smaller tube, a Foley catheter or a smaller Foley catheter, much better than nothing at all, because that'll keep that tract open. Any questions on gastrostomy tubes?
Nothing in the, oh, we have a question from Thatcher. Thatcher, I will unmute you again.
Can you hear me?
Yes.
Yes.
Yeah, thank you. At what point do you consider removing a G-tube for a patient if they've gone X amount of time without using it? And how is it best managed? Is that something we can do in the office and allow it to heal on its own, or should they be seen for a G-tube removal?
Great question. So often in general, if they're not using the G-tube for a couple of months, then I would wait another month or two, particularly if it's over the winter season and they might have a chance to get sick and they may need some additional fluids or G-tube during that time. Then we would remove it. In general, there's two ways. One is you could just remove it and see what happens. If the tube has been there less than 6 months, and you're more often than not removing the tube, it'll close up on its own without anything to do. If the tube has been there more than a year, often it'll need a surgical closure. That means we actually have to go in and do a little bit bigger operation to close it, and it would be a general anesthetic. 6 months to a year is kind of, dealer's choice what you want to try, whether you want to remove it or you want to go straight to the OR. I would still advocate trying to remove it because you can always put a tube back in if it's leaking a lot. I think if you wanted to try to remove it, I think just that would be great. What we tend to see is that if it closes very quickly. And then the first 24 hours when you may see a lot of leakage, but after 24, 48 hours, you'll have very minimal leakage. The only thing to keep in mind is if there's any mucus or any little bubbling out that happens more than a week later, it's probably still open, and you may want to send to us to make sure that they don't want it to have it surgically closed. But you're more than welcome to remove it. But in general, if it's, I'm always very cautious. If you haven't used the tube for a couple of months, I usually wait at least another month, make sure you don't use it again, then I would take it out. Okay, how are we doing on time? I think we're getting close. So I just will go, any other questions on G-tubes? I know that's one that tends to have a lot of questions.
We don't have anything else in the chat and no hands raised. We're about 5 minutes till 1, so I'll probably put a link to the evaluation in the chat for anyone who has to hop off, but you're welcome to keep presenting for as long as you'd like to. I think everyone's finding this super helpful. And the presentation, again, will be recorded, and so if folks do have to drop off, they can always view the rest of the recording later on.
Great. Well, this is just kind of rapid fire things that we see a lot of, and we very, very much appreciate all your referrals on inguinal hernias, hydrocele, umbilical hernias, perianal abscesses, lumps and bumps, and all of these things. Keep them coming. Just wanted to make sure there was no major questions. I'll go through a couple quick things. I'm sure you know all these things because patients come in, they're very well educated, they already know everything, and they're just like, when do I do surgery? It's like, okay, so we just kind of answer some basic questions, but you guys very much prepare patients very well for us, and they're very educated and ready to go. But inguinal hernia, as you know, a much higher incidence in premature babies, as well as much higher incidence in boys compared to girls. It tends to happen more frequently on the right side, and bilaterally is about 10% more common in premature babies again. We know that this is a patent processus vaginalis, so there's no muscle repair, there's no mesh that we use to close it. All we do is put a stitch to close that patent processus vaginalis. We could do that open or laparoscopic. I think my partner in the past has given a talk about laparoscopic repair. Both are equally great and effective, so you can go either route with them. The question is, what do you do with the other side? If a patient shows up with a right inguinal hernia, what should we do with the left side? There is about a 5 to 10% chance of contralateral hernia. but exploring it open or doing an operation there's risk of damage to the vas deferens and the testes. And so the question is always when to explore the other groin. In my prior practice, we put a scope in everybody. So when I fixed the right side, when the hernia was open on that right side, I'd put a camera in that hernia sac and look at the other side. And this is kind of what you would see on the other side. You can see on your left, this is a girl, and that's what a hole would look like where the hernia is. And on the right side, this is a boy. You can see the vas deferens going across and into the ring, and you see the testicular vessels going in, and that's what the hernia would look like from a laparoscopic view. And so we can go ahead and fix that. So that is a good indication for looking at the other side. It's been the practice here of all the other 12 surgeons to just do the one side and not put a camera in. So that's been kind of the practice we've been adopting here, and what we tell families. But that is a possibility of putting a camera inside. Any questions on inguinal hernia? Umbilical hernia, as you know, is, you know, all that. And just to emphasize, our typical age of repair is 4 years or older. The chance of an incarceration or problem is very low. The last one I want to touch on before the end of the hour is a perianal abscess. This is one that you see quite a bit. It happens in very frequently in patients who are less than a year or even a few months old, even more common. And it's just bad luck. In an adult, it can be very complex, as shown here. You can have them going above into the pelvis. You can go in the sphincters, transsphincter. Fortunately for us, we see almost all of them are A. They originate, they're very superficial, and they go straight into one of the pits, or excuse me, one of the crypts inside at the dentate line. And so that's what we end up seeing. What you need to know is a couple things is antibiotic management is the key, is augmentin. Tends to be polymicrobial. They may need a bedside IND, which you're more than welcome to do. It's just a little emla cream and a little lance, whether it's with a needle or a blade. We used to think that draining them increases the risk of a fistula and ano. We don't think that anymore. So if they're really symptomatic and it looks like it's easy to do, feel free to drain it. It'll make the patients feel a little bit better. But in general, if they do warm baths twice a day, 3 times a day, kind of wash the area, scrub the area, it'll often drain on its own along with the augmentin. What you need to know is about 50% of patients with a perianal abscess will actually go on to develop a fistula and ano. And it's frustrating for these families. And they'll present with recurrent abscesses or persistent drainage from that site. So it's not that we did anything wrong as far as should I have drained it or should I just treat it with antibiotics, but half the patients will develop a fistula and ano, which may end up requiring an operation. I think that's all I had. I just had some additional ways for you to refer patients to us. If you just Google our hospital, Seattle Children's Hospital surgery referral, you'll come up with this page, and it'll have all the links that you need to help refer to us. But as I end, I want to see if anybody has any other questions for me. And again, I want to thank you for your time and thank you for joining and giving me the opportunity to present to you. Really enjoy it.
Thanks, Dr. Lee. We did have one question pop up in the chat from Liz. She says, apologize if I missed it. What age do they generally repair reducible, I think? Sorry, I am not a clinician. These words are not in my vernacular. No. So, hernias in an infant.
So inguinal hernias, because there's a much higher, let me back up. Umbilical hernias, the risk of incarceration is extremely, extremely low. And in addition, the majority of those will close on their own. So we wait to 4 years old because there was a study that showed that was safest for patients from an anesthetic standpoint and a recurrence standpoint. And the chance of an incarceration is very low. For inguinal hernias, the chance of incarceration is higher the younger you are. So it's inversely proportional to your age. So as soon as we see patients with inguinal hernias, we like to repair them. Now, there's only one kind of condition, is if their babies are premature. If we wait to their post-conceptional age is more than 52 weeks, then their anesthetic risk is lower. So if someone's born at 24 weeks, ideally we wouldn't fix them until they're 28 weeks old, which can be a while, right? They're 7 months old now. And therefore, that's what we would look at if they can wait. If it's a hernia that's causing problems or looks like it's carcerating, we'll fix them at any age. But on the premature babies, we tend to wait till they're 52 weeks post-conceptional age. Great question. You didn't miss it. I didn't say anything.
Thank you. And Liz said thank you in the chat. I don't see any other questions, so I think we may be good to wrap up. Dr. Lee, thank you so much for your talk today. To everyone who attended, we always appreciate your presence here and engagement. As a reminder, I did put a link to the evaluation in the chat. We will send out a PDF of Dr. Lee's slides and a link to the recording in about a week to anyone who registered. You're welcome to share those with colleagues. And we hope to see you all again soon and hope you have a great afternoon.
Great. Thank you.